Hi, I'm Dr. Mark Fryman, the Chief of Hepatobiliary and Pancreatic Surgery at St. Joseph Medical Center here in Towson, Maryland. Today's medical tutorial is on gallbladder cancer. Gallbladder cancer obviously involves the gallbladder, so just a quick anatomy lesson like we normally do. This is the liver. And this is the common bile duct. The gallbladder rests in the gallbladder fossa, which is actually a part of the liver, so it's actually the gallbladder is actually attached to the liver. And then it's also attached to what we call the common bile duct. This is the common bile duct, and this is the gallbladder. And today we're going to talk about gallbladder cancers. And gallbladder cancers are cancers that actually arise inside the gallbladder. And these types of cancer are actually one of the more common cancers in the biliary tract. Unfortunately, they're often diagnosed late, and they're not one of the more frequent cancers that we operate on because the majority of the patients are inoperable. But it does involve 2% of all cancers. And interestingly enough, females are usually affected more than males. These type of cancers tend to be in the more elderly, beginning in the 7th decade. What are some risk factors for gallbladder cancer? Well, probably in the United States, the most common risk factor is just a history of inflammation from gallstones. And up to 90% of people who develop cancer of the gallbladder actually have stones. So the longer that you have stones in place causing chronic inflammation, the higher the incidence of gallbladder cancer. The majority of these cancers are what we call adenocarcinoma, or beginning in the glands. Occasionally you will see a squamous cell cancer of the gallbladder, but that's few and far between. Now, determining operability and determining what type of operation needs to be done in patients with gallbladder is part of the initial evaluation. Essentially, the gallbladder, let's see if we can just draw a gallbladder here like this. There are several layers lining the gallbladder. So if we were to look at it, there's what we call a mucosal layer. And right under it, this space here is called the lamina propria. And then there's a muscular layer. And then there's connective tissue, and then the serosa. So let me so what I did here is I went again just to show that there's a mucosal layer, and then one layer deep is what we call the lamina propria, and then there's a muscular layer, and then there's connective tissue and a serosal layer. So mucosal, or mucosa rather, lamina propria, muscular, and serosal. So these gallbladders are staged or classified based on the degree of invasion. So if there's a tumor that's just touching or just arising from the mucosa, this ends up being a T1 lesion. And now if there's one that just goes through the mucosa but is in the lamina propria, that actually is a T1A. And then everything else is either it goes T2 to T4 based on the degree of depth. So why is this important? Well, as a surgeon, it's important because it can potentially change the operation, and also from the patient's perspective, gives you an idea of the risk of having disease elsewhere. For example, the deeper these tumors go, the higher the incidence of lymphatic involvement, and the deeper they go, there's also the higher the incidence of direct extension into the liver bed. So this is a good segue into how we treat these tumors. Okay, so how do we treat these cancers? Well, the majority of these tumors or cancers are referred, at least to my practice, after the gallbladder has been removed. Occasionally, the CAT scan will show suspicion of more than stones, but of a mass. And I recently saw a patient where the surgeon actually was a student. The general surgeon was astute enough not to take the gallbladder out, thinking that there might be a cancer. So we will be able to do this operation in one stage. But the majority of times, the gallbladder has been removed. And if the cancer ends up being a T1 cancer, we usually just leave it alone, and the treatment is just cholecystectomy. If, however, the lesion is T2 to T4 to T3, even to T4, the operation changes. So after the gallbladder has been removed, so we usually have a stage because the gallbladder has been removed. The pathologist has looked at it. So once again, if it's a T1 or just confined to the mucosa, we won't offer the patient anything more than just observation. Probably get a CAT scan every 3 months in the first year, just looking to make sure there's no evidence of recurrent disease. These categories, and it's usually the T2, T3 actually. The T4 may or may not be operable. The operation that we perform is removal of segments 4-5 of the liver, which is basically taking a large chunk of the liver, in common with a portal lymph node dissection. So along this common bile duct, there are a series of lymphatics, and what we do is we completely skeletonize and clean up all the lymph nodes along the hepatic artery, along the common bile duct, and the portal vein. If the cystic duct margin, this is a different scenario. If the cystic duct margin, however, and it was not a high tumor, but let's say this was a cancer that was here, or a cancer that was not here and there was lymphatic spread. If the cystic duct margin, which is on the specimen, is positive, or if there's evidence of cancer here, many surgeons actually advocate resecting the common bile duct in conjunction with removing all the lymphatics. And sometimes it's an easier operation to actually remove the common duct because the lymphatics will come up with it. In that situation, this biliary system has to be reconstructed. So we're talking about the situation where the biliary system has to be reconstructed, and I've showed this on previous videos. So it's a segment 4-5 resection of the liver, basically, or a large glorified wedge resection with reconstruction. And this is a lipobal, and once again we do what's called a Roux-Y hepatic jejunectomy. Now, situations with gallbladder cancer like Klatskin tumors, if there actually is direct invasion of the liver, and typically if it's less than a few centimeters, let's say less than 3 centimeters, and the patients can tolerate it, a formal right hepatic lobectomy can be performed, where you actually remove the right lobe of the liver to get clearance of the cancer. But the majority of the times, if it's operable, usually a 4-5 resection can be done. A lot of times, as patients have had cholecystectomy and the omentum is stuck to the gallbladder fossa, and sometimes the portion of the omentum needs to be removed. Most surgeons also advocate doing elliptical excisions around the port sites of the laparoscopic cholecystectomy. If the gallbladder wasn't placed in a bag, these cancers tend to seed the abdominal wall readily. So elliptical excisions of the port tracts are also important for surgeons re-exploring. So in summary, gallbladder cancers are relatively rare, only 2% of all cancers. They are a more common form of biliary tract cancers. The minority of patients are actually treatable by operation because the majority of times patients have had metastatic disease or locally advanced disease that's inoperable. The standard operation is removal of a portion of the liver with the lymph nodes around the common bile duct. For more information, please feel free to visit my website, www.liverandpancreascancer.com.